congratulate Jaideep and his team, who has organized very nicely this conference. This is the second edition, I think. Hats off to him and congratulations also. A round of applause to him also. This is, as she correctly said, this is prior to lunch. So the topic also, as you have seen, it's a brittle one. Now, why brittle one? Two reasons I will tell you. The first one, number of cases of brittle diabetes what we see are less. And second thing, though we have various pharmacological as well as technological and educational approaches for treating diabetes, still we have certain number of cases which are said to be brittle, which are said to be unstable. So you all will agree with me, when we are controlling patients, we are like Dhoni. And when we get brittle diabetic patient or an unstable diabetic patient, we are like Rohit Sharma. So at the end of this session, I won't say you will be Dhoni, but your approach will be like Dhoni. So this session we'll just see what is the definition, because definition is little bit confusing. Nowadays, hardly we use this terminology like brittle diabetes. We use unstable diabetes. Previously, they used to say that it's a brittle diabetes, but nowadays we say it as an unstable diabetes. So what is the definition of that? What are the causes? Just now we have seen various nice presentations since morning. Just now we have seen the secondary diabetes or various endocrinal diabetes also. They may also turn into brittle diabetes or unstable diabetes. How to assess that brittle diabetes? If suppose a case comes of unstable diabetes, how we can assess that case? Then groups of patients. This is just for approach, because we cannot classify brittle diabetes. If you see any of the association, if you see any of the organization, whether it's a ADA, whether it's a WHO, they haven't classified this as a brittle diabetes. But yes, we can group certain number of patients as an unstable diabetes or a brittle diabetic patients. Then treatment strategies. What are the treatment strategies for this brittle diabetes? And lastly, take home message. So by definition, you can say any of the case because of the dysglycemia, and this dysglycemia may be hyper or hypo, and because of that, if there is a recurrent or prolonged hospitalization, and because of that, if there is a disruption of that particular patient, means patient is frustrated as well as doctor is frustrated. In that case, definitely you can diagnose that case as a brittle diabetes or unstable diabetes. Now, considering that there are three forms of the brittle diabetes or unstable diabetes. The first one is the recurrent diabetic ketoacidosis. Means certain patients will have recurrent diabetic ketoacidosis. Maximum number of patients, if you see of brittle diabetes or unstable diabetes, they will have this recurrent diabetic ketoacidosis. Second form of brittle diabetes is they will have predominant hypoglycemia. Now, how sort of hypoglycemia? There is a need of assistance actually, or there will be need of hospitalization just because of hypoglycemia. So this will be second form of brittle diabetes or unstable diabetes. 17% of the person will have this, but if you see 24% of the patient will have mixed type of dysglycemia. That means either they will have hypoglycemia or they will have recurrent diabetic ketoacidosis, and because of that there is a prolonged hospitalization. Because of that there is a recurrent hospitalization, and that disrupts actually the patient's life, as well as it will be a frustration for physician or diabetologist. Now, what are the causes? There are various causes actually. If you go through this slide, there is a malabsorption. If there is a malabsorption, then there will be dysglycemia. Of course, you will agree with me. Drugs, certain drugs. Just now we have discussed about steroids. Steroids or certain other drugs also. They will cause this, and there will be risk of the diabetic ketoacidosis. There will be risk of recurrent diabetic ketoacidosis, which may cause unstable or brittle diabetes. Then certain other causes like autonomic neuropathy. They say that if there is a follow-up of brittle diabetes or brittle diabetic case, 50% of the patients after 10 years or after 20 years, there will be autonomic neuropathy. And because of this autonomic neuropathy, again there will be instability, there will be instability in glycemia of that particular patient. So various causes are there, but one cause which is very important one, and 74% of the patients will have this cause. That cause is a psychological one. You might have seen various cases also, like factitious hypoglycemia we have seen, or factitious diabetic ketoacidosis also we have seen, malaria of the patients, malaria by the patients, we have seen they will skip insulin, and because of skipping of this insulin, also there will be increase in blood sugars and recurrent diabetic ketoacidosis. Now this is just because of the psychological case or because of the psychosocial status of that particular person. So 74% of the patients will have this cause, that is psychological cause. Now this is alexithymia. It's tongue twister actually. If it has been psychiatric conference, then it would have been a best paper actually. Because most of the brittle diabetic papers, if you see the papers which are published on brittle diabetic, most of the cases they say that there is a emotional disturbance in most of the unstable cases or most of the cases in brittle diabetes. And alexithymia is nothing but an emotional disorder. You might have seen various females. They are emotionally disturbed, and because of this emotionally disturbance, there is increase in blood sugars or recurrent diabetic ketoacidosis, or they will increase the insulin dose on their own, and because of that, there are hypoglycemic episodes. Now, both these dysglycemia, that is hyperglycemia or diabetic ketoacidosis or hypoglycemia, if it is causing hospitalization, definitely it's a brittle case. So, emotional disorder is the main cause, social aspect is the main cause for brittle diabetes. Now, there are certain personality disorders also. You might have seen this in day-to-day practice also. There are certain personality disorders, and because of these personality disorders also, they will adjust their dosages of insulin accordingly, and because of that, there is a risk of hospitalization. There will be recurrent hospitalization, there will be prolonged hospitalization, and this disrupts the life of that particular patient or of that particular person. So that case is also a brittle diabetic case. Now, one study has been conducted. After 10 years, they have seen that mortality rate was 19%, and after 20 years, mortality rate was 50% of brittle diabetes family. Means number of cases are less, of course, but those cases are at a risk of death. Why this is so? Just because of the dysglycemia, just because of the fluctuations of the blood sugars. So outcome, if you see, of a brittle diabetic patient, though they survive, means 50% of the patients will survive after 20 years even, but the suffered candidate will have significant complications and will have significant complication burden also. So that will be frustrating for a physician who is treating, and that will be frustrating for a patient even throughout his or her life. So outcome of brittle diabetes is miserable actually, and that is why assessment is very important one. Now, how we assess this glycemia, or how we assess actually glycemia? By fasting and postprandial as well as HbA1c, but it won't give you an idea about brittleness. And for that, we can manage, or we can rather assess mean plus or minus standard deviation. But if you see the glycemia of majority of the patients, it won't have a Gaussian curve of normal distribution, and that is why mean as well as standard deviation will not give you an exact assessment for that particular case. So, which are those? Which are the assessment? How we can assess the brittle diabetic case? We can have bench, we can have mode. Now, though these are research based, actually hardly we do in a clinical practice, but if in an individual case you do this, that is bench is nothing but a mean amplitude of the glycemic excursion, or mode, which is nothing but a mean of daily differences, then definitely you can assess whether this case has a brittle diabetic, and accordingly you can treat that brittle diabetes also. Now, this is for hyperglycemia, but for hypoglycemia also there are certain scores. You might have gone through this hypo score or class score. Class score is nothing but a questionnaire. You will have to just ask a questionnaire to that particular patient, and you will get a score. If it is more than 4, then definitely the patient will have more of hypoglycemia or severe hypoglycemia. The same is the case with the hypo score. For hypo score, but patient's involvement is very important. Means patient will have to record the hypoglycemic episodes, and whether he or she got any assistance in that hypoglycemic episode. So accordingly, we will give score, and if this score is more than 90th percentile of the normal, then definitely that person will have severe hypoglycemia. So accordingly, we can assess the various scores, and these scores will assess definitely whether the case is having brittle diabetic or unstable diabetes or not. But these are for research purposes. What we can do in a clinical practice, we have CGMS, we have AGP. So CGMS and AGP will definitely give you an idea whether this particular case is having instability or instability in glycemia. So this is the case. You can clearly see there are fluctuations, and most of the readings they are hyperglycemia. So definitely this person will have an unstable diabetes or brittle diabetes. In future, he will require recurrent admissions or hospitalizations, and definitely this will be a brittle or unstable case. Now, for approach, or for treatment strategy, we have just grouped this brittle diabetes into 4 groups. Now, most of the cases, if you see of brittle diabetes, there will be insulin required. In practice, in 14 years of practice, I have hardly seen 3 cases of brittle diabetes. 2 were type 1 and 1 is a geriatric patient who is a type 2 basically. Now he is off insulin, off OADs, but he was having hypoglycemic episodes. So we can group the patients accordingly in brittle diabetic cases in 4 categories or 4 groups. The first one is the younger patients. Mostly they will be females and mostly they will have these psychological disturbances. Most of the females, they will have these psychological disturbances, and because of that, there is a brittle diabetes. Because of that, there will be glycemic instability. Second one, certain medical conditions. Just now we have seen various causes, which causes actually unstable diabetes or brittle diabetes, like endocrinopathy, as well as certain drugs if the patient is using. Because of that medication also, there will be instability in glycemia. So this is the second group. The third group is a geriatric type 1. Life expectancy is increasing because of the insulin analogs. In the morning itself, we have seen a nice lecture, insulin signaling as well as various newer drugs. Because of these newer drugs, because of the insulin analogs, the life expectancy of the type 1 patients is increasing. And because of that, we are seeing certain patients which are type 1 in a geriatric age group also. But if you see geriatric population, there are certain other comorbid conditions also, and which causes fluctuations of blood sugars, which causes instability in glycemia. And because of that also, there will be brittleness, there will be unstable diabetes mellitus. And the fourth group is seen in lower socio-economic group. You might have seen this also. Lack of insulin access is unfortunate actually and associated with even food insecurity. So this is seen in lower socio-economic. Means they will hardly have access to the insulin and there will be food insecurity also. We have shocking news from the World Cup also. Argentina lost against Saudi Arabia. So you might be a Messi while treating a diabetes mellitus in a diabetology. But while treating the brittle diabetes, there has to be a holistic approach. So there has to be teamwork actually. Of course, while treating diabetes, we use this teamwork. But while treating particularly unstable or a brittle diabetes, there has to be a team approach, there has to be holistic approach. Now how that approach should be? So this is according to the groups. Just now we have seen 4 groups, and these 4 groups can be approached for the treatment strategy. The first one is psychological diseases. If a younger lady who is having psychological disease, then you should consult a psychiatrist, and that psychiatrist also should know certain parts of diabetes even. It's a particular case actually, and you will have to treat hand in hand along with the psychiatrist. Second one is severe glucose variability due to coexisting medical diseases or because of certain medications or the drugs. So you will have to identify those diseases. Just 5 minutes now. You will have to identify those diseases or you will have to cut down the dosages of those medications. Third one is geriatric type 1. Of course, CGMS is the best choice. You can see the fluctuations and accordingly you can adjust the insulin dosages and accordingly you can treat that brittle diabetes. But insulin access, you can take the help of certain medical social workers and you can give access to those patients who are not having actually insulin access just because of the economy. Now this is a take-home message. It's a bit difficult to quantitate the degree of glycemic variability, and that is why I said the definition of brittle diabetes is means it's a bit difficult to define a brittle diabetes because glycemic instability we cannot quantify, we cannot quantitate. Secondly, identifying an underlying cause of glycemic instability is very important now. Whether it's a psychological or whether it's a other cause like disease or any of the medication, that we will have to identify and accordingly we will have to treat the brittle diabetes. Exclude psychological problems if there are, and you should take the help of psychiatrists even. Optimize the insulin therapy, of course we are doing that, and there are certain alternative approaches also for brittle diabetes like IIT as well as IPII. IPII is nothing but the intraperitoneal insulin infusion, or IIT is nothing but the intraportal islet transplantation. We can do that also. That is for only if the person is having hypoglycemia unawareness, and because of that, repeated hospitalizations are there. In those cases, we can use. So patients with unstable or brittle diabetes are not failing actually. We should not say that these patients are failing, but we should say that these patients are actually suffering and they are having great risk. So we should treat them. I must conclude this session with the quote by APJ Abdul Kalam. He says that there are 4 things which are very important while achieving anything. So if you want to achieve the control in a brittle diabetic patient, you should have an aim. Secondly, you should acquire knowledge. Why the cause? What is the cause actually for this brittleness? And then hard work. Yes, with the psychiatrist if it is having any psychological cause. And lastly, perseverance has to be there. Means there has to be consistency. Patients should not get frustrated as well as diabetologists should not get frustrated. Thank you.